Our speaker today is Dr. Kevin Suzuki. He received his dental degree from Nova Southeastern, fantastic school, and his periodontal specialty training from Temple University, another fantastic school. He practices periodontics and implant dentistry at Puget Sound Perio in the Seattle area. He's a diplomat of the American Board of Periodontology, as well as the ICOI. He's also a faculty member at the Mish Resnick Institute. Dr. Suzuki, I'm going to turn it over to you right now for your lecture on peri-implant disease, diagnosis, and management.
Good morning, everybody. Thank you for the opportunity to be here, and thank you to Glidewell. Let me get my screen sharing here so we can get the slides up. And we should be good to go there. Just let me know if you need me to do anything else, Dr. Park. So our topic today is peri-implant disease. We're talking about diagnosis, we're talking about management, and I'm going to present some maintenance strategies to try and help these that you can do in your private practice and also for educating the patient at home. Very specifically, this is the agenda of topics that I hope to address today. We'll talk very specifically about the definition of success currently as it resides with the American Academy of Periodontology for implants. We'll talk about defining the peri-implant disease entities, and there are 4 new categories of implant designation that were recently published. We'll talk about briefly the etiology and pathogenesis of implant disease. We'll talk about various treatment modalities that are out there, and I think you'll find it interesting that there's not necessarily a great consensus on what's the best way to treat peri-implantitis. It's very case specific. And then, of course, maintenance strategies as promised from the title. So just starting out, I think it's important to mention that anatomically, natural teeth and implants have very distinct differences around them. And this can account for also the reason why we see disease entities manifest around implants differently than natural teeth. We all know from dental anatomy that there's the inserting Sharpie's fibers, various periodontal ligament orientations that attach the tooth to the crestal bone and the alveolar housing. It's often seen in histology studies and suggested that these various attachments actually serve as a resistance barrier to the progression of infection, which is one of the reasons why we theorize that disease progression, especially with periodontal infection, progresses much more rapidly in many cases around implants than around natural teeth, because implants don't actually have inserting fibers and they don't have nearly as many primary ligaments surrounding them. There's no insertion, and so therefore there's less anatomic resistance to disease in these cases. These are actually some statistics that I found interesting. They're actually a little bit old now. This was presented in the International Congress of Oral Implantology meeting back in Vancouver in 2017. And so I thought it was kind of interesting, at least at that time, and this is changing over the years. But currently there are about 10 recognized specialties in dentistry, of which there's actually no specific implant specialty. Now, various specialties such as periodontics or oral surgery might try to add implantology to their title for their boarded diplomats, but there's not a specific specialty on just implantology. It was calculated that in the United States, there was about 2 million implants being placed annually by clinicians, and that was, of course, back in 2017. And at that time, this number was actually increasing by at least about 500,000 implant units per year, which means more and more clinicians are learning, training, and placing implants in their own private practices. Statistically, in the literature, we've seen that implant success and what we quote is typically around 92 to 96%. So if we take an average failure rate of about 5% over these 2 million units at that time, what that means is that there's about 100,000 failing implants every year. So what could this mean for us and for practices? Well, that could designate a whole new specialty on just implant complications. And so we'll share some more information about these specific complications today. So my question to each of you in private practice is, what are you going to do with a situation like this if it comes into your office on Tuesday next week, when you have a little bit of bone loss or you see radiographic changes? These are cases where we may not have done the implant. Maybe it's a case that we've inherited. Or cases like this, where the bone loss gets so advanced, now we're in a situation where you've got maybe some implants that are okay, some implants that are floating in bone. This particular case I'll show you more about upcoming in the slides and how I treated it. And what does it take to get to a situation like this where the determination is catastrophic failure, where these cases just outright have to be removed, possibly start over, or consider an alternative option? Well, I think you might find it interesting in one of the more recent studies in the Journal of Periodontology that patients have a very different perspective about implants and failures and disease entities. This is a specific study from Hamle Wang's group from the University of Michigan. And what you'll find specifically from this, they actually conducted a survey of multiple and thousands of patients at the University of Michigan that went into the graduate periodontology and the pre-doctoral department going in for implant consultations. When questioning these patients about implants and their expectations, they found that the patients often had understanding and perception of peri-implantitis and their prognosis generally to be poor. And this result reflected that patients had very unrealistic expectations about implant dentistry. And many of them were quite disappointed if they came in seeking care for an implant problem, the very fact that implants could even have a problem in the first place. I think what we find is a lot of patients see these marketing campaigns, they think that implants are the end all be all, and they realize that, well, maybe if I just get an implant, that'll solve all my problems. I never have to brush my teeth again. I don't have to take care of it. And we know that this is not the case. We know that implants require even more attention and more care in order to keep them successful. And so what do we currently know about the state of treating implant problems and about implant disease? Well, we've noted that up until this time, it's been very difficult with the literature to actually define a specific definition of peri-implantitis. There's not been great agreement on the different parameters and what the threshold is. We know that there's not necessarily a perfect understanding of the root causes for implant disease. We have identified some risk indicators, and there are many of them that are being researched, and there's more research coming out all the time. We know that peri-implant disease, and specifically peri-implantitis, which I'll get more into, is an inflammatory process. It depends on the host's immune response of the body in relationship to certain types of bacteria. We know that it often affects permanent loss and destruction of the hard and soft tissues around the periodontium, around implants. It's a progressive problem, and without treatment, it is going to progress and exacerbate over time, eventually to the point where the implant could be lost. We do know that some of the processes in the bacterial species associated that are damaging are very similar to the periodontitis manifestation, but we also know there are differences. As I talked about before, anatomically, we often see that disease entities around implants are much more fast progressing and much more aggressive than around natural teeth. And so this is just a general summary slide showing all of the new categories that were published recently by the American Academy of Periodontology and the European Federation of Periodontology. So this was a joint convention effort. It took several years of planning. It took place over the course of 3 days, and then there were several months of deliberation of the material and arguments made to make these new publications and new categories. Perhaps if I work with Dr. Park in the future, I can come back and show a little bit more about some of the new periodontal disease entity classifications. But specifically for today, we're focusing down here on this lower panel. They re-looked at and redefined 4 different designations for states of implant health. There's the actual definition of health, mucositis, peri-implantitis, and then the newest category, which I won't spend much time on today, but it deserves a whole lecture unto itself, the new category of soft and hard tissue deficiencies around and before implant placement. So we'll start very specifically with the definition of health. Let's look at what success should be identified as. So according to the new AAP and EFP classifications, let's look at some clinical examples here on the top. And so we can see the crestal bone is basically flush with or very close to the crestal platform once restored. Gingiva, just like in natural healthy teeth, should be firm and pink, tightly adapted around the restorative collar. In most cases, if we can see stippling, we consider that ideal. Specifically looking at the published criteria, though, to diagnose health upon visual inspection, we should see an absence of inflammation, and that includes a lack of erythema, a lack of edema at the margins. We should not see enlarged gingival tissues. We like to see a lack of bleeding on provocation or a lack of bleeding on probing, and that was one of the specific hallmark signs that was most researched in all of these new classifications. When you actually see bleeding around a tooth sulcus or an implant sulcus, that's a specific designation to look more into that because there's an inflammatory and sometimes a bacterial process going on. We also see that the probing depths are very dependent on soft tissue height. It's not uncommon to have an implant with a restoration where the pocket depth is actually deeper than 2 to 3 millimeters, which we might expect around a natural tooth. You can have a healthy peri-implant sulcus that could be 4, 5, or even sometimes 6 millimeters of probing. As long as there's no bleeding, that's health. Now, it's important to have a baseline probing once the implant is placed and restored. Typically, we recommend probing within about 9 months after it's placed and restored to get a baseline for the sulcus, or the clinical depth of the pocket around there. Because if we see changes over time, such as an increase, that could significantly show a change in health. And then also very specifically is a commentary on bone changes or bone loss. With health, there should be an absence of further bone loss or progression. And they do note that it's past the initial healing or initial remodeling. What do I mean by that? Well, in a lot of implant systems, it's very common once restored to see some crestal bone remodeling within the first 6 months to a year of up to 1 to maybe 2 millimeters. Oftentimes, this is down to the first thread of implants. There are specific systems that have some designs with platform switching and things that don't always see that. But these are the definition and criteria we have right now, AAP published for peri-implant health. Let's talk about the next designation of a disease entity now, what we call peri-implant mucositis. This is basically what we consider the equivalent to gingivitis around natural teeth. It's defined as an inflammatory lesion of the mucosa surrounding the endosseous implant. However, there is no loss of supporting peri-implant bone. And so radiographically, we're still not going to see any bone changes past initial crestal remodeling. Clinically now, the distinct differences which we will notice are bleeding on probing. We'll see erythema or swelling of the gingival tissues. We may or may not see suppuration. And also it could affect some slight increases in pocket depths depending on if the tissue is inflamed and enlarged. So here's some specific hallmark signs of peri-implant mucositis, or the gingivitis component, if you will, of implant disease. When we think about the conversion of health from gingival health to mucositis, we do know that there are specific published cause and effect relationships. We can take dental students or periodontal residents, pay them money to allow them to tie ligatures around their teeth and not brush their teeth for several weeks. And then over time, what we'll see is a progression such as this picture on the lower left, where we'll see a buildup of biofilm. We know that this biofilm that builds up over time and accumulates causes specific inflammatory responses in human subjects. But we also know that if we take those ligatures away, we end the studies and we reinstitute very strict hygiene measures, that these students go back to brushing and caring appropriately for their teeth and reinstituting their prophylaxis or maintenance visits, that this process can be entirely reversible. That's the big hallmark distinguishing factor, is that this is a reversible process. Now, this slide on the lower right actually shows that when you get this buildup of this experimental biofilm and these microbial colonies, they form these complex communities where they will form these large congregations of bacteria, and then they can break off and spread in large aggregates to other sites of the mouth. So it's really important to make sure that plaque control is instituted, and we'll talk about that in maintenance. Let's look at the specific definition of the disease entity of peri-implantitis now. So the strict case definition in this new publication by the AAP is visually similar to some of the previous symptoms that we've seen. So signs of inflammation, again, like edema, erythema, bleeding on probing, and or suppuration may or may not be present. We also are seeing an increase in probing depths. And so again, it's important to have that baseline from initial restoration if possible. And then of course, the very specific distinguishing hallmark sign that differentiates mucositis from peri-implantitis is progressive bone loss. So radiographically, we will see changes past that initial remodeling. Now, what about if you inherit a case where a patient's had an implant placed and restored somewhere else? What if it's a patient we've never seen before and we didn't do the implant ourselves, such as in most situations probably we encounter in private practice? Well, for the first time in this AAP EFP publication, they actually define a specific criteria here that's asterisk on the bottom half of the slide. And so I thought that this was particularly helpful as well. Now we have a threshold for implants previously restored and placed somewhere else. When we don't have initial radiographs, we don't have initial probing depths, we'll specifically look at the radiographic criteria. And so if we see a bone level change of 3 millimeters or more from the crestal platform, also, in addition to that, we may or may not be able to compare with probing depths. So if we see a threshold probing depths that are 6 millimeter or more with profuse bleeding, and again, it's very important they designate there's actually bleeding present, because that was one of the hallmark signs they researched more specifically, that bleeding is a sign of disease activity or inflammation. So I thought that this was particularly helpful for, as in most clinical situations when we inherit implant cases from elsewhere, how do we define the threshold of peri-implantitis? And so if we think about the progression of disease, it's important to understand that peri-implantitis, as I've mentioned a few times before, tends to be more quickly progressing and more aggressive around implants than around natural teeth. This slide on the right actually shows the histological model of periodontal destruction and the B and T cell and chronic responses in the tissues and bone destruction around natural teeth. This was an article every periodontal resident has to memorize when they're in school, published by Page and Schroeder back in 1977. Well, we get a similar process to this around implants. The only difference is it's a lot more quickly progressing and it's more aggressive of a destruction of the surrounding bone. Again, as I mentioned, there's no inserting Sharpie's fibers or numerous periodontal ligaments inserting around and about the implant to try and create a greater resistance to disease activity. And so what we see is in cases where implants are newly restored, oftentimes when peri-implantitis manifests, it might progress very quickly and very soon after the restoration. So there's an early commencement. And then as I talked about, the rate at which that destruction occurs can be quite aggressive compared to what we might expect around a natural tooth. Also, interestingly, there were studies that were quoted in these new publications about maintenance. We found that patients that are very well maintained or very compliant with coming back for their 6-month prophylaxes or their 3 or 4-month maintenance visits tend to have a very low incidence of peri-implant disease. In this case, it was quoted about 18% of patient populations. Patients that are non-compliant or sporadically compliant and don't follow the instructions of how often to come back for maintenance tend to have a much higher incidence. Some studies quote the implant disease incidence as high as 43% of implant patients in situations like that. As I mentioned, there are very specific risk indicators for patients that will develop these disease entities that are commonly shown in the literature. The 4 most specific defined ones here that we know are well established include patients with a history of periodontitis. If they're genetically susceptible to bacterial infection or disease around their natural teeth, one would expect that they may also be very susceptible, if not more so, to infection and bacterial breakdown around implant sites. We've known long that smoking and tobacco use is a very significant contributing factor. Tobacco smoke and the additives create localized anaerobic environments that are selective for more destructive periodontal pathogens. We also know that it changes the oxygen tension in the gingival sulcus, and there can be local suppression of immune reaction. We've known that poorly controlled diabetics typically have poor healing and are much more susceptible to infection as well. Typically with implantology, we try to make it a goal in the literature of having an A1C or a hemoglobin glycated A1C value of about 7.0 or less, depending on the physician's direction, as considered stable for implant therapy. Patients that are higher than that may not be in well compliance or may have some significant systemic issues going on that make them more susceptible to infection, to these glycation end products, to these chemotactic defects that increase infection susceptibility. And then also, of course, as we might expect, poor plaque control and lack of maintenance. Well, we've already talked about studies that establish that, but that's been very well established as well. So think about the accumulation of biofilm, highly causing and high risk for breakdown of periodontal issues around implants. Other areas of future research that are starting to kind of broach into the literature and are starting to have more attention would be some of these factors here. So areas that have not so great supportive keratinized mucosa, or if there's an inadequacy of keratinized tissue around implant sites. Now, it's very controversial because there's some literature to suggest that it may not matter so much around natural teeth. There's other literature in another camp that suggests that it's very important and it can actually increase susceptibility to inflammation and breakdown. We've seen a number of studies, some by a famous periodontist named T.G. Wilson, that show excess cement can be significantly associated with bacterial breakdown and accumulation. Sometimes these complications of excess cement may not show up for anywhere between 2 to 7 years on average. We know there's a number of patients that may be genetically more susceptible, and there could be different risk factors affecting their immune system. Patients that have systemic conditions, and there's been a lot of attention to patients nowadays with autoimmune disorders that may have chronic conditions that can make them less able to fight off infections, or they might be hyper-responsive to infections around implants. We've seen a number of iatrogenic factors. As more and more clinicians take variable levels of training for implantology, there's different levels of proficiency when the implants are placed. I'll show you a couple of cases with some restorative questionable situations that some of you might cringe at as we go through the presentation. Occlusal overload is something that my mentor, Dr. Carl Misch, had advocated investigating quite significantly for a long time with implantology. And so his perspective was that a significant number of biomechanical complications might be caused by occlusal overload or occlusal complications. So it's really important to check the occlusion of the implant at that recall exam every year when the patient comes back. One of the newer things that I found quite interesting as well was the attention on corrosion of titanium particles. And so there can be a breakdown or a corrosion or solution-mediated dissolution of titanium surfaces of implants. And there's been studies that suggest that these titanium particles will perforate and penetrate into surrounding tissues and bone. There could be autoimmune reactions to that, and we just don't know right now what the clinical implications of that are. But there is a lot more attention to the fact that titanium can corrode and those particles can spread out into the surrounding periodontium. And so specifically, if I just very briefly touch on a topical approach of this peri-implant soft and hard tissue deficiencies, just to give you an idea, Here's some of those cases as promised that are cringeworthy here, as you can see. So there's a number of different categories now that specify you can have defects related to implant placement, you can have defects related to implant failures that have been removed, or even before implants are even placed, they call them pre-implant placement defects. So hard and soft tissue issues, such as the left side there, you can see implants that have been placed anatomically in an incorrect position where it's perforating through the lingual plate, or iatrogenic damage to adjacent teeth because implants were placed too close. Maybe a surgical guide wasn't used if it should have been. Very significant bone deficiencies left over after implants fail, or significant abscesses around natural teeth. Endodontic lesions that are remnant afterwards and not completely cleared out before implants are placed. That lower right picture was shared to me by Dr. Matthew Palermo, a prosthodontist from Temple University, one of my mentors, that showed these cringeworthy cases of these very poor prosthetic outcomes that are extremely difficult to treat and might need to be completely redone. And so this is just a topical approach for some of these other topics that are a new category presented by the AAP. But again, that's a whole nother lecture. So if we look at specific treatment considerations for dealing with these complications, with these implant disease entities, we know that there's a couple of things common, and this is shared by probably many clinicians, but we know that peri-implant disease treatment is often not predictable. We could try and treat the same site multiple times, and sometimes, depending on the patient, we may not have an appropriate outcome. If we look at situations like this, where there's a paucity of hard and soft tissue and there's infection there, we open up the case surgically, who can imagine how predictable it could be to try and gain back bone along the buccal plate here when the implant is infected, sitting outside the housing of the bone, and there's bacterial infection there. We know that it's very complex to do these treatments. We know that these surgeries are often difficult to perform. In every case that I work with patients, I have to preface it with a discussion about the cosmetic and the aesthetic expectations for afterwards. Mrs. Jones, this gum on the front of this implant may not quite look the same after we're done with it. Yes, it's infected and it needs to be treated, but it's possible that the crown might look a little bit longer afterwards, or the gums might sit a little bit lower along the site there. We have to be upfront with patients about the expectations. Again, as I first mentioned, they have oftentimes these expectations that these implants are invincible and that they're going to be perfect forever. And that's just not the case in situations where there is a complication. We know that specifically for peri-implantitis, the disease entity, in most cases, non-surgical therapies such as just sulcular debridement and instrumentation is usually ineffective. And I'll show you why with some of the categories as we come up here in some of our case examples. And very commonly with these complications, we're entering into what we call a multimodal approach of therapy, meaning that we're employing multiple techniques. We're not just doing a surgery to clean the area out. Oftentimes we're employing various biologics like bone graft, regenerative biologics, membranes. We might even be incorporating lasers and other technology to try and produce some type of regenerative response and preserve the soft tissue and gain more hard tissue as best as possible. So if we look at our treatment goals, what do we want to accomplish with trying to address these complications and problems? Well, you might find that these are shared very similarly with treatment goals around periodontitis, around natural teeth. We want to arrest further bone loss. We want to try to reestablish a healthy peri-implant mucosal seal, because again, remember, we're not actually promoting attachment. We also want to try to maintain shallow pocket depth, so we have an anatomical situation that's selective for aerobic bacteria and not for the more destructive anaerobic pathogens or periodontal pathogens. And so we do this by various techniques of either eliminating the osseous defect or resective techniques, and or incorporating some type of regenerative techniques such as bone regeneration, and in some cases actually even some gingival augmentation as well. So my references for the remainder of the presentation actually come from these two textbook publications here, published within the last 2 to 7 years. So there's the Avoiding Complications Oral Implantology textbook published by Dr. Mish and Dr. Resnick from chapter 18, specifically on periodontal maintenance complications. And more recently, I had the privilege to work with my father, Dr. John Suzuki, on chapter 41 from the new Mish's Contemporary Implant Dentistry, published mainly by Dr. Randolph Resnick. And so we have a chapter we put together on mucositis, peri-implant diagnosis, classification, etiologies, and therapy. So those are good references as well to refer to some of these categories, which I'm going to present to you. In these chapters, there are specific categories for what threshold of disease and what type of treatment can often be suggested or most likely to be effective in these scenarios. And so if we look at a situation of the most ideal, or what we considered peri-implant health initially, they're defining in these categories as success or optimal health. So clinically, this will present as an absence of pain, no tenderness on function, no mobility in the restoration or implant. We'll see less than 2 millimeters of radiographic bone change from the initial surgery. We'll see pocket depths of less than 4 millimeters when probing. There should be no exudate or bleeding on probing present. So clinically perfect or optimal situation that we want to have for all patients with implants. And so our management of this situation would be normal maintenance and normal support of the patient's home care. Once we start getting into the next disease entity category of what we had already talked about as peri-implant mucositis, or sometimes called perimucositis, would be clinical conditions that are somewhat similar in the fact that there's no pain or mobility. We'll have less than 2 millimeters of radiographic bone change or bone loss. But now we start to see those mucosal signs of inflammation, as we've talked about in the previous AAP category. So edema, erythema, there may be bleeding on probing or suppuration present. And they're starting to designate that there could be pocketing of about 4 millimeters, but it could be more than that. And so in these situations here, where we actually start to have some bacterial inflammation and disease activity, you may consider these any combination or all of these factors on the right-hand side for management. So more frequent supportive periodontal therapy visits, maybe coming in every 4 or 3 months. Non-surgical debridement, where we're actually specifically appointing the patient to subgingivally curette or scale the area with curettes or instruments that are not going to scratch or damage the implant surface. Trying to enhance the patient's self-administered care, their hygiene at home. And so I'll talk about some ways at the end under maintenance to try and do that, such as using oral irrigators like water picks or water flossers, or perhaps special brushes to get under overhangs. We may consider adjunctive antibiotics, whether they're locally injected, such as Arestin or doxycycline, or systemic antibiotics, such as combinations of amoxicillin or metronidazole, or other antibiotics for patients that are allergic to those. And then we'll also consider there could be some soft tissue components. I talked about keratinized tissue being a very significant issue that's gotten more attention lately. I've seen a lot of situations where patients don't have appropriate keratinized tissue and they have this ongoing long-term inflammation despite our best treatment efforts. So gingival grafting might be something that comes into play. And as I mentioned as well about biomechanical complications, occlusion is really important to make sure that we're checking at each of the recall visits and in situations where there might be some initial inflammation present. Also prosthetically, if the restoration is designed with poor access, that could be something that can significantly challenge the patient's ability to take care of the restoration. If we look at our next disease entity now, what we call the survival mode or early peri-implantitis, it's very similar to the previous category in that there's no pain and mobility, but now we're starting to see radiographic bone changes, as we might expect the disease entity hallmark sign with peri-implantitis. So 2 to 4 millimeters of radiographic bone loss. The other category way at the bottom, also we designate an alternative of less than 25% bone loss along the implant length. So that's the very important distinguishing hallmark. As we move forward, you'll see more and more changes in the percentage of bone loss here. We also see the same signs of perimucosal inflammation that we might expect, like bleeding on probing, edema and erythema at the gingival margins, probing depths of 4 millimeters or more. And so again, there's very similar management here with this very early stage of peri-implant disease as we've seen before with more frequent maintenance, specific appointments for non-surgical debridement, increasing the patient's ability to try and care for them at home with some of the techniques they're using. Again, incorporating antibiotics possibly and investigating if there's soft tissue defects, prosthetic issues that could be modified, or occlusion. And so this is identical in terms of treatment management for very, very early stage peri-implantitis. Let's look ahead now at more significant changes, what we consider the moderate peri-implantitis category. Now we're starting to see situations where patients may or may not have symptoms of variable pain or discomfort in the area. We still see a lack of mobility with the restoration and implant. Now we're starting to see deeper pocket depths present in the area, such as 6 millimeters or more. Again, we're still seeing bleeding on probing and suppuration, as you might expect with other inflammatory signs. And now you can see a higher threshold for bone loss, between 25 to 50% of the bone loss of the implant length. And so we have very distinct criteria with the radiographs where we're designating this as moderate peri-implantitis. And so the management now significantly changes. We're seeing techniques such as surgical reentry, as I briefly alluded to earlier. So we're reentering the area to try and debride and clean off the implant surface. We may have to revise the implant surface somehow or modify it, such as removing threads. It's controversial, but there's publications that support the use of various laser techniques that may or may not be successful with implant surface debridement. We're also seeing various biologic components for attempts to try and remove the bacterial smear layer on implant surfaces, such as decontamination like EDTA or citric acid or tetracycline slurries. Again, there's not a lot of great literature to support any specific decontamination product, but many clinicians would agree that you have to do something to try and remove all the bacteria, because just mechanical instrumentation may not be enough. And then also incorporating regenerative techniques that I'd mentioned earlier, this multimodal attempt for therapy where we're using biologics, barrier membranes, and bone grafts. Now, there was the final category here of the most absolute catastrophic failure, what we called clinical failure or advanced peri-implantitis. So the clinical conditions here would again include signs of inflammation, as you might expect, like edema and marginal erythema. They're now distinguishing that usually there's pain present upon function. Probing depths are much more advanced, such as 8 millimeters or more. Again, we're seeing bleeding on probing and or inflammation in these categories. We're seeing bone loss of greater than 50% of the implant length. And so that's the very significant distinguishing hallmark now, is that you have greater than half of the bone loss missing, we'll consider much more aggressive treatment. If there's mobility present, that's also a really catastrophic sign of failure. Now you have to make sure you distinguish if it's mobility of just the restoration, such as a loose prosthetic screw, or if indeed the implant has lost integration and the whole implant is mobile inside its osseous housing. If you're not able to get any success with controlling the exudate and you tried other treatment attempts, then we would immediately convert over to this category of clinical failure if it's even a previous category. And of course, they designate if the implant's no longer in the mouth, that's an absolute failure that you'd want to consider some type of additional treatment, such as replacing the implant or an alternative. And so what are the options we have for management? Well, surgical reentry and revision surgically could be an option. Sometimes once we get to a really advanced state, it's less likely to work. We may consider laser therapy as well, such as in the previous category. And this is the state where now we have to consider, is it time to throw in the towel and just completely remove the implant? And if we do so, is the patient willing to try and start over and try again? Or is it better to go to an alternative? So situations like this, radiography that you can see down here, where there's very significant bone loss around this restored implant, despite the fact that it's splinted. Or in this lower category, this implant case was actually a case from a surgical teaching course that I attended, where one of the attendees placed the implant with a cover screw. They let the patient go, and the patient never showed up for their post-operative appointments for about a year. Then the patient came back with a premature exposure and an anaerobic bacterial infection around an implant that had otherwise looked pristine when it was placed. And so we have very significant infection here that's compromised it to the point where it has to be removed. Now, there was another category that's interesting that we published that was called the retrograde peri-implantitis. This is for some of those situations where maybe you don't necessarily have a probable defect from the crevice or sulcus, but there's some type of retrograde or retroactive disease process around the apex of the implant. And so in situations like this, we theorize that maybe there's an endodontic lesion that never quite resolved, or if a situation where perhaps an implant had perforated through a buccal or lingual plate and somehow an infection developed. And so in these cases, we'll often see variable mucosal inflammation. Radiographically, we'll see some type of periapical, it almost looks like an endodontic lesion around a tooth, or a rarefying lesion around the apex of the implant. There's oftentimes some discomfort or pain or tenderness around that specific area of inflammation. And in a lot of cases, we'll see some type of a fistula or drainage present. And so with these, our options of management also include possible surgical reentry and revision or removal of the implant. And the interesting thing about surgery in cases like this is there have been some publications and clinicians that will consider an implantoplasty, where they'll reenter the site. Similar to doing an apicoectomy or a natural tooth, they may choose to try and resect an apical part around the implant. And I can tell you surgically, it's extremely technical and difficult to do, and it's really messy. There's a lot of implant shavings that get all over the tissues, but it is an option that has been published and considered by some clinicians. So let's look at a couple of case reports here in the final time that we have left, and some examples of treatment modalities that are available to us. I thought, as I mentioned earlier, there's some publications by T.G. Wilson. He's a periodontist that does a lot on maintenance and follow-up, and also cement complications. And so I'll show you a non-surgical case first. So in this particular case here, this is a radiograph where we can see that fortunately, this patient had at least a cement retained restoration with radiopaque cement. So at least we could see it on a radiograph if there was some left over. But according to Dr. Wilson's study, he theorized that up to 81% of peri-implant disease can often be associated with excess cement that's not removed. Of those cases in his study, 74% of those patient complications resolved once the excess cement was removed. In a lot of cases, the only way to effectively remove a lot of that more apical placed cement was through surgical access and reentry. And so his justification for a surgical approach was to remove all that etiological factor. This is a radiograph of one of my cases that I inherited. This patient came into my office. She'd had this implant restored less than a year. She was having inflammation and some discomfort in the area. Now, radiographically, we can definitely see some radiopaque accumulation there, which we designate as cement. Clinically, when I felt around the sulcus with a probe, I actually was able to feel tactily that there was a deposit around the restorations. So some of you are probably seeing this picture and cringing because you see me using a metal probe around an implant. What I would offer to you is that there has been some literature more recently that suggests that if you're very careful with, a metal probe and you're not deliberately trying to scratch the surface of the implant, you could be okay and safe and not causing detriment to the implant surface. One of my colleagues in my residency, Dr. Behnam Farquhar, had published a histology study and also a microscopic study designating implant surfaces and roughness, and found that actually when he was probing gently around implants, as long as you're parallel to the surface, you're not likely to cause any kind of surface alterations. Now, again, there may be those of you that still are skeptical of that, and I respect that, and plastic probes can still absolutely be a really great way to diagnose and evaluate as well. So I still advocate plastic probes for those of you that want to be conservative about it, and that's okay. And so in this particular case here, you can see that the gingival margin was a little bit kind of darker and purplish. There was some cyanotic response to the vasculature in the tissue because of the infectious inflammatory reaction going on here in this case. And so showing you the next slide here, we had basically brought the patient back for local debridement and instrumentation with titanium curettes to make sure we didn't scratch the surface. You can see all these different deposits and flecks of cement that I was able to remove just by mechanically instrumenting around the site. We took a new radiograph and brought her back within about 5 or 6 weeks. Now, radiographically, I can only see that on the mesial and the distal aspect, there were no radiopaque deposits present. And of course, tactily, I felt circumferentially around the entire restoration. But that's actually a pretty favorable response there, where you can see the tissue is tightly readapted on the bottom image here on the lower right. After 5 or 6 weeks, there's no bleeding upon provocation anymore, and the patient doesn't have the discomfort. So I think that's been very successful. Now, if we look into more aggressive tactics or resective surgery, we borrow these resective techniques from periodontology, disease around natural teeth, where we're surgically re-entering areas, often altering the bone, sometimes in a disfiguring manner, to reduce the pockets and repositioning the tissue back in a way that may be more apically positioned. We may also want access to be able to provide biologics. So I'll show you this case here, which we kind of designated as a more moderate peri-implant situation, more moderate peri-implantitis. Now, the decision was made here to surgically re-enter this area, starting in the upper left there with the radiograph. As you can see in the top middle picture, there was some definite occlusal issues contributing, I think, in this case, as the occlusion was quite heavy on that second premolar restoration there. So I worked with a restorative clinician to actually have them remove the restorations. We placed healing abutments on for better access. And then we actually were able to surgically re-enter the site and have a much less obscured perspective of the area to surgically debride and cleanse and detoxify those implant surfaces. Because the bone loss here was basically horizontal in nature, I didn't feel confident being able to place regenerative biologic graft materials. And so in this case, we did warn the patient that it would be a somewhat disfiguring surgery. Now you can see once we've reapproximated the surgical flaps, where the prosthetic components are showing, this tissue was in a more apical position. After the disease entity had resolved, we made the decision to restore, although this could be a situation where maybe we go back later and attempt some additional regenerative techniques. But in this case here, because it's horizontal bone loss, it's extremely difficult to gain vertical height of bone around implant surfaces like this. And so we have been upfront with the patient about the cosmetic expectation of some of the metal and the threads showing. Now, it's not ideal, I know, and aesthetically it's not the best situation, but in this particular case, it was the best that we could gain for this patient, and she didn't want to take them out and start over. There's various ways to try and decontaminate and detoxify. Various companies make these types of titanium bristle brushes, which I really like to use. It's something that you would insert into a ratchet handpiece or your implant motor with saline irrigation. Now, I also wanted to share, this is a more recent laboratory study that was just published last month in the J Periodontology. It's the journal endorsed by the AAP. In this particular study from Stuwani's group, they actually looked at various methods of detoxifying and removing bacteria around implant surfaces. And so just to give you a frame of reference, what they did was they took both smooth and rough surface implants. They were able to apply E. coli bacteria, where they incubated them to grow various concentrations of E. coli bacteria around those implant surfaces. They looked at it under a microscope and then attempted to remove all of the E. coli bacteria or debride that biofilm off these rough and smooth implant surfaces with different techniques. And so just to give you a frame of reference, if we look at There's two columns of pictures. I would want to draw your attention more to the one on the right side of each column, which actually has little white spots designating what the implant surfaces look like with those various bacterial colonies on there. And so the top is what we call a positive control. So what the implant surfaces would look like with all the bacteria present and no attempt to remove it. Stepping down, they tried submerging the implant surfaces in EDTA. As you can see, it wasn't very successful. Again, they tried submerging the implant surfaces in chlorhexidine for about a minute. Some increased success there, but still quite significant bacterial colonies. And going all the way down, some of the other approaches that they tried were mechanically just disrupting and scrubbing the implant surfaces with a gauze soaked in chlorhexidine. So they actually had quite good improvement in removal of bacterial colonies with that. Just standard subgingival curettage or instrumentation mechanically, they found somewhat of a favorable response to removing bacteria. Also, the titanium bristle brushes, you can see that slide is called TIB, and so the bacterial species that are left there are fairly reduced. And then the last one was implantoplasty, where they actually take handpiece burrs and grind away the exterior threads and try to smooth the implant surface. And so some of the more effective ways of trying to decontaminate the surface was through chlorhexidine soaked gauze, scalar curettes, titanium brushes, and implantoplasty. So in addition to those techniques surgically accessing the area, we also talked about these multimodal approaches of applying biologics, such as barrier membranes. If we can seclude a sterile space and allow tissue to be readapted over top of it securely, we can sometimes see regeneration of natural teeth of periodontal ligament, bone, and soft tissue reattachment. Well, what if we were to try to employ that technique as well around implants? So here's a case that I had inherited as well a couple of years ago in my practice here in Seattle. You can see very specifically that there is cement or some type of radiopaque accumulation on the distal end of the implant there. We were getting probings of 6, 7, actually one case I think was 8 millimeters. Signs of erythema and edema. And so you can see upon surgical reentry of this area, very distinct deposit of cement there and very distinct circumferential bone loss around the implant that didn't quite show up entirely on the radiograph. So once we thoroughly debrided that and used some of the techniques we talked about with the previous study with chlorhexidine irrigation, saline irrigation, EDTA, I tried some other approaches to try and detoxify that surface. Then we also employed regenerative bone material with absorbable collagen barriers and regenerative Emdogain in this particular case, which is an enamel matrix derivative biologic regenerative product. We've reapproximated the flap and sutured into place here and then allowed it to heal for anywhere from 8 to 9 months. This is when the patient came back after the sutures had been removed at about the 2-week mark. And then this is the images here from the 9-month reevaluation where you can see the bone level is still retained fairly well. And so this was a regenerative approach from when comparing start to finish that was fairly successful so far. Not all the cases ended up like that. Here's a particular case here. I'll show you in the final moments where we had a catastrophic failure. This patient had splinted implants with restorations. She had a maxillary denture, so you wouldn't expect an occlusal overload here. But for whatever reason, she developed a very distinct infection that was very advanced. So the decision was made to remove these implants. There had very specific and distinct osseous defects that were very difficult to regenerate, although we attempted anyway. So we completely debrided the area, placed regenerative biologic bone allografts and barrier membranes with collagen. We took a panoramic at about 3 or 4 months to see, and it looked like so far we were gaining some decent regeneration above that nerve canal. And she had a fairly good result, but she did not want to undergo implants again, understandably. Now, it's been controversial, but there are some laser techniques out there as well. One of the most publicized techniques is called the LANAP, the laser-assisted new attachment procedure around natural teeth. Around implants, it's called the laser-assisted peri-implantitis procedure. And in this case, we have these disease defects. There's various steps of using the laser fiber with a certain energy setting to completely obliterate and destroy the infected tissue. We'll then still use mechanical instrumentation to debride the implant surface and actually disrupt the surface of the bone, what we call a regional acceleratory phenomenon, where we're decorticating the bone to try and gain better access to the blood vessels for regeneration. We'll use the laser on a second pass under a different setting for a coagulation step. And that's here in the middle. And then progressing on, we want to try to minimize the blood clot by applying pressure. There's also a very aggressive occlusal reduction that's performed to reduce any kind of occlusal trauma in these cases. And so clinically, this is what it looks like from left to right. This is the coagulation step, firing the laser in the sulcus around circumferentially each defect. Using these piezo units with irrigation to completely debride and remove the etiology, and then using the laser on a second step or a second pass to cause a coagulation or biologic blood clot seal. And so this is a particular case of mine where this is an implant that I had placed after extracting the tooth and preserving the site with bone. The implant was nicely restored. the patient disappeared for 5 years, and then they came back with discomfort and bone loss here. And so in this particular case, we chose to implement the LAPIP technique. We're using laser therapy to debride the area. That lower left picture typically shows what the situation will look like when the patient leaves that day after the laser instrumentation. So it does look like some aggressive scaling root planing, but there's no flap reflected, there's no sutures. And then afterwards, with just as little as 4 months after treatment, we started to see some bone changes. At about 7 months, a little bit more promising bone regeneration. And this patient is continuing to do well. Just showing you one other technique, and I'll just go to the before and after due to time. But in this particular case, this patient had very distinct peri-implantitis of 7mm pockets. You can see pretty moderate to advanced bone loss on the left picture. And then on the right radiograph, we've seen a hint of some radiographic regeneration in as little as about a year. And so that's also been a case that's been fairly promising. So I'll spend the last 2 or 3 minutes a little bit on maintenance. I'm actually going to skip most of the points on this first slide, but it's important to understand we custom tailor the maintenance program to each patient. I do advocate probing around implants because radiographs only tell part of the story on the mesial and distal. Of course, it's affected by how effective the motivation of the patient is, also their dexterity. If you do recognize infection, it's important to be aggressive and treat it as early as possible. And I can't stress enough, and I think Dr. Levin would agree with me, that it's not a good idea to try and let insurance dictate what the maintenance interval will be. If the patient needs to come in more often than just 4 or 3 months, I think it's very important to try and explain to them they should come in more often. I have patients that come in every 2 months sometimes because their hygiene is so poor. I found that these interproximal brushes are really effective because they do a really good job of filling in the embrasures around implant restorations. I've also found, and some of you are going to, of course, snicker at this because there's been all kinds of political jokes about bleach and hypochlorite, but in periodontology for a long time, we've had a technique published by Jorgen Slotz where you can actually dilute hypochlorite, about 2 teaspoons of bleach to 8 ounces of water, and that could be used as an antibacterial rinse, especially for patients that can't tolerate chlorhexidine or Crest Pro Health or Listerine. But more importantly, you can use this antimicrobial rinse as a subgingival irrigant, such as in an oral irrigator like a water pick or water flosser. It's really effective, especially in those deep anaerobic sites, to try and debride the areas out. I do advocate scalers other than metal because those can scratch implant surfaces. Although plastic curettes are very difficult to use, I found that titanium curettes are a lot more effective in cases with subgingival instrumentation. There's also a lot of research to suggest that these pressurized implements such as ProfiJet can be very effective with a polishing slurry such as bicarbonate around defects. If you use ultrasonic instruments, there are safe plastic tips. And then in the office, you can also incorporate antibacterial solutions such as a dilute povidone iodine. Now, this is something where you'd want to dilute saline to iodine in a 1-to-2 fashion. Iodine to saline in a 1-to-2 fashion. And this is povidone iodine you buy at the pharmacy. It's a 1-to-2 dilution if you're using an irrigating syringe, or if your hygienist has like a piezo instrument where you want to use that as the irrigating solution, you can for antibacterial. Of course, you can't use it in patients with thyroid diseases because of systemic absorption. You want to make sure you have adequate suction. You can also use that hypochlorite solution as an irrigant with ultrasonic instruments as long as you have adequate suction. In summary, there's a couple of things here to show what's safe and what's detrimental around implants. So you can use metal or ultrasonic tips around implants, and you're sure to cause detrimental problems there. So you want to avoid that. You also want to avoid stainless steel tips. Ultrasonic tips with sleeves are safe if they're plastic. These air polishers I talked about, like the ProfiJet, are safe. Non-metallic scalers like Teflon or titanium, and of course, rubber cups and points. So sorry I ran a couple minutes over, but I really thank you for your attention. And this is my email. If you have any questions, I welcome collegial discussion. Thank you very much.